everybody. Reporting to you again from the Glamour City, Hollywood.
The health disparities and the challenges to access in rural areas are longstanding. And I can tell you a little bit how we think about it, and things we actually learned from the pandemic. Telehealth, as an example, that was in addition to the incredible development and deployment of vaccines, the use of telehealth in some of the rural communities has been very positively received both by patients and health professionals. So I think that, to go back, and I'm in public health. So the area that I work on is the ways to keep people out of the hospital and thinking about preventing as much disease and illness and the risk factors for those diseases that we can. And that extends to urban areas and becomes, in many examples, much more challenging in rural areas. And that's everything from those determinants of health, our healthcare, and much more. They are our environment, and they are social behavioral factors, our economic factors, whether you have enough food or if you have a house or a place to live. It's all those habits and behaviors, of course, and then part of our genetic makeup that we continue to learn much more about. And some of the research, in my opinion, on microbiomes is absolutely fascinating in terms of options for the future.
If you love listening to this show, please consider giving a rating and a review on Amazon Alexa or wherever you listen. We want to continue bringing you this amazing content, and part of our ability to do that means that we need a big audience. Now, it may not seem like much, but rating and reviewing the show will help more people find us, just like how you found this show. Simply on any podcast platform, search for a show, scroll down to the bottom, and push 5 stars. It's that easy. Thanks for supporting the show. Today, I'm joined by Dr. Jen Carney, Master of Public Health Program Director and Associate Dean for Public Health and Health Policy, and Professor of Medicine at Larner College of Medicine at the University of Vermont. Welcome to the show today.
Thank you. Delighted to be here.
So when we look at the broad, let's call it healthcare industry, there's a lot of things happening. So certainly in terms of pharmaceuticals have really undergone some significant changes because of the IRA and the way Medicare is getting reimbursed, and even things around patent protection around some of those drugs. And it's having a significant impact that is having to trim their cost and bottom line. And then from a hospital perspective, you have a lot of private hospitals that are doing a lot of mergers and acquisitions. And they're telling their regulators that they're not going to reduce those hospital capacity when in fact they often do close down hospitals because they want to make sure that they're getting almost a monopolistic power in terms of some of those regions. But again, all of these things are really more to do with kind of the urban metropolitan areas. But when it comes to rural regions, I wonder if you could talk to us about what's really happening or what's been happening. And do they have the kind of healthcare that most urban or bicoastal regions kind of take for granted?
Thank you for that question. It's a tough one. And I think that the health disparities and the challenges to access in rural areas are longstanding. And I can tell you a little bit how we think about it, and things we actually learned from the pandemic. Telehealth, as an example, that was in addition to the incredible development and deployment of vaccines, the use of telehealth in some of the rural communities has been very positively received both by patients and health professionals. So I think that, to go back, and I'm in public health. So the area that I work on is the ways to keep people out of the hospital and thinking about preventing as much disease and illness and the risk factors for those diseases that we can. And that extends to urban areas and becomes, in many examples, much more challenging in rural areas. And that's everything from those determinants of health, our healthcare, and much more. They are our environment, and they are social behavioral factors, our economic factors, whether you have enough food or if you have a house or a place to live. It's all those habits and behaviors, of course, and then part of our genetic makeup that we continue to learn much more about. And some of the research, in my opinion, on microbiomes is absolutely fascinating in terms of options for the future. So what's it think practically about rural areas? And so I'm in Vermont. And so we're in a time of year, we just got a snowstorm, and then it'll be melted next week, and then we'll enter into a period where we have a lot of mud and rural roads and back roads, and you could just imagine these non-paved, muddy back roads that are hard to navigate, right? So if you need to get healthcare, it's actually physically challenging to get that. All right. So access to healthcare. It may be that you don't think about smaller hospitals. Hospitals are if you're really ill, but I think about having the number of physician offices, nurse practitioners, primary care that you need. That's fragile. That part of the system remains very fragile in the rural areas. And then think about the access of the transportation we mentioned. Part of it's also the insurance, which we're doing very well with, but it's also the knowledge of when you need to go, what you need to go for, what can you do in terms of clinical prevention, the screening tests that have been demonstrated to prevent you from dying prematurely from something. How can you get access to resources, for example, to quit smoking? And tobacco use is one of the risk factors that is higher in rural areas. The access to preventive services in some cases, like cancer prevention, is lower. So think about the system as a whole and those component pieces. And then in the rural parts of the state, it's much harder to physically get there. The number of people that you can go to see is far less, and that system is sometimes tenuous. So making those connections becomes really, really important.
So you covered a lot of different facets, and first and foremost, it is incredibly a complex topic to say the least. And when we say rural, it's not this kind of homogeneous geographic or demographic area that we're talking about, but it's fairly diverse from mountainous regions, arid, dry regions to the kind of places that Vermont is that you're talking about. But generally, for these people, they may have to travel anywhere between an hour to a full half day, full day, just to get any type of primary care. They have to think really hard in terms of, can they afford it? Is it worth the effort and time? And then, they probably are lacking lots of information. And then, of course, you talked about a lot of the other factors like social economic aspects. There's some correlation depending on the kind of agricultural regions that they're in. You're going to have higher degrees of depression, maybe even use of opioids and job loss or job displacement. There's a lot of structural issues that are inherent with rural regions. Can you talk about maybe more from a kind of regional aspect throughout the country, how different they are and some of the uniqueness and the way that some best practices have worked?
There are great resources that are publicly available. And I suggest, and this is something I teach a lot of students, is to look at the health status of your region, right? And there's, just as an example, there's a website called County Health Rankings and Roadmaps, and that was originally funded from a Robert Wood Johnson Foundation grant to develop publicly accessible. You can look at any state in the country. You can look at their profile as a whole. And then you can go down and by county. So you can look at, for example, a state and look at their rural counties, and it gives you a whole range of the commonly used and accepted health and social indicators of the population. And I suggest that, in terms of, are there some system practices and best practices? Yes. I always suggest look at the health status of the area that you're interested in. So, and we know that those health and social factors are so intertwined for people. Post-pandemic, one more example here in our rural state of Vermont, is we saw challenges with food security. People did not have enough high-quality food to eat. That was a national problem also, worse in rural areas. We saw tobacco use in rural communities tends to be higher that puts people at higher risk for later cancer and heart disease and chronic conditions generally. And then we also saw a need for substance abuse, all kinds of substance abuse treatment and access to that. So some of these things were worse in the rural areas. Flipping to the bright side and some of the best practices, we learned the tremendous potential for telehealth and coordinating that. So, and for certain uses. So if, for example, mental health conditions and continue to loom large in our populations, and they are often even more challenging in rural areas. And some of those counseling can be provided through telehealth services. It's critically important on the ground, in my opinion, to connect that. We have to connect the academic centers, the federally qualified health centers, the rural practices. And we're talking not just about doctors and hospitals, we're talking about nurses, nurse practitioners, physicians' assistants, social service agencies, departments of health, as an example of most states have autonomous county and local health departments. How do we connect these community resources to make some of these things accessible? And it might look differently in every single state, but there's data available and people can do this in a very, in my mind, common sense kind of way.
Well, thank you for that response, and I do appreciate it. And I do think that there's a lot of data that's available that people can actually very much laser focus into. And you start to focus on telehealth. I think that's a really important topic because of the fact that physical accessibility is limited, transportation and mobility, but the fact that they can actually still get high quality care, including mental health, I think that's really profound, especially given the fact that when we talk about health, we think about it more from kind of manifestation of symptoms, but the root cause is probably because of the mental health and other issues that they're dealing with. So looking at people holistically, can you talk about the different dimensions of telehealth? You mentioned the therapy aspects and some other public services. What are other things that telehealth and telemedicine is starting to make available?
People can use it for all different kinds of services. As an example, in terms of access to primary care, many primary care offices here are now offering that for certain conditions. There's some conditions where you really need to see someone in person, but for many conditions, you might be able to start with a telehealth visit. And for follow-up, for example, someone who's come in and they might be treated for a chronic condition, you might be able to do some of that follow-up in a telehealth visit. Imagine that if you live an hour away from that specialist in an academic center, and how convenient that is, and how that will help you be a better partner in your own healthcare, which bodes very well for improved health outcomes.
And it works really in a kind of symbiotic way, right? Because for the physicians or the primary care providers, it also allows for them to provide high quality care, but at scale, right? And it also lowers their cost of doing business as well. Now, in addition to telehealth aspects, can you talk about some of the self-care things as well as training, materials, education, and even the resurgence of home diagnostics, everything from continuous blood glucose monitoring to other types of diabetes and blood pressure, a lot of things that are out there that's allowing for people to be able to measure their own set of biometrics.
Yes, there's a lot of different components to the question you just asked. I mean, let me just start, and I'll come back to sort of the health literacy in an era of a lot of misinformation, health misinformation, and how do we really improve the health literacy and the quality of the information people are accessing on an individual and community level. That's something that we're working very hard on. And then that's really something that public health schools and programs are very, very involved with. So that you want the default to be that people become aware of great sources of high quality science and healthcare information, right? If they go on searching for a question, You want them to go for the right places. And what we know about where people are going, well, they might not do that. They might be getting some off social media that may or may not be correct, or even if they ask a friend or relative, we certainly like to have more and more people have just a foundational knowledge of how do you tell if all the information that you're finding for yourself is accurate or not. How do you do that? And there's some great resources to do that. That's something that we have our students working on. As I said, schools and programs in public health, and certainly individual health professionals are working very hard to really make sure that people, when they ask those questions, they get the answer that is good for their health, as an example. Another dimension, I would say, is around the use of individuals and communities to bridge. They're kind of a bridge from the community and the individuals in that community to healthcare. And the general term for that is community health workers. These are trained professionals, but they don't have to be doctors or nurses. They can help people bridge to services. Sometimes those resources can be found in local health departments or in public health departments, and that sort of landscape looks different depending where we live. And other places that can be more specialized. So, for example, there's great evidence that using community health workers to get people into cancer screening, for example, can be very, very impactful. So we have to look at, in my mind, sort of the people in the community and sort of how we get that information out is kind of some of the foundation building blocks for how we make high quality information available to people and then make the services that they need more accessible to them.
You bring up a really very interesting point, and certainly we saw some of these issues around misinformation, disinformation during COVID. Matter of fact, I think just today there was a big article about the microbiologist that was espousing, I believe, malaria drug for COVID, for example. That's, of course, been debunked since then. So it's really problematic in terms of getting information from hearsay, social media, and neighbors. And then it's even more problematic if those community workers themselves are misinformed and telling others about it. How do you go about making sure at the grassroots that there is pristine, quality, research-based facts that's being disseminated?
I think it's very hard. I think it's a process. And I think that is something that is really squarely in the consciousness of everyone I know in both healthcare and public health. And so how do we think about that? I think about it as how do we connect our systems? So for example, it might be have doctors and nurses in medical offices or hospitals. It might be people who work in public health or in those local health departments. It's a network of health and social service agencies that have a presence in different communities. And to ensure that everyone's talking to each other and is aware of all the available sources of great scientific and medical information. So that's one way. The other thing is that what we know about communities is that we need to work with who are those trusted leaders in communities. And that really varies community by community. And we're doing some work in this and thinking about this in the area of climate and health, because that's been something both in our state, we've had floods. We know that climate change both across our country and globally is a huge issue, and what we're trying to learn from our work in that space is how do we help communities identify trusted leaders on health? And that could look differently. That could be an elected official. That could be a school nurse. It could be a trusted health professional. It could be just a community leader generally, or a faith leader. And it really varies. So making sure that we have those connections among all the different people that people may trust for that information, I think that's really important. Another side or aspect of that is also, I think we've made assumptions in science and healthcare and academic settings and in government about delivering the information to people as opposed to flip that around. And I call it community humility. Ask people how they want to get that health and medical information. And we've been doing some of that work through one of our federal grants. And what we asked people, for example, we had a population of older adults, and they were living in senior housing. And what they wanted their health information from the Department of Health or the academic medical center or the Centers for Disease Control. And they wanted it on a flyer that was printed out and had cartoons on it and was handed to them. We asked them, they told us. So that's how we prepared the information. The concept, I think, is more generalizable, which is, no matter what community you're working with or population, whether that's a geographic population or different age of individuals, ask how they would like that information, and we can't make assumptions. I think that doing that sort of over and over again can help us counter a lot of that misinformation that's out there.
I really like this point, and I wish this point that you're bringing up is actually brought up more often and repeatedly, because it goes beyond just respect. It's this notion that people are more likely to accept the approach or the way that they basically have explicitly indicated. So rather than forcefully telling them in some manner that they don't perceive as trustworthy, you're basically agreeing to respect their dignity in the way that they want to, from whom and how and what that they want to receive this information from. And then therefore it's a lot more credible. Now, going back to my previous question around biometrics, is that for some time, I think the healthcare professional has been somewhat apprehensive around wearables, and certainly not treating wearable as medical or FDA-approved types of diagnostics. But with that said, we are starting to see, continuous blood glucose monitoring systems. We're even seeing very sophisticated rings from Samsung and Oura Ring and watches that can capture a lot of information. And again, even the wearers, I think, are aware and acknowledge that these are not fictitiously made up numbers, but these are numbers that's reading from their bodies. How is that being reinforced by medical professionals, and how are the people in the rural regions starting to use more of these types of wearables and self-diagnostics?
I don't have any specific data, for example, on rural or not, and can't give you a real precise answer on that. I will tell you that major medical organizations are looking at that and asking those same questions. And sort of if you look at our overall health status metrics as a whole, as a country, in an aging population, we continue to see a rise in chronic conditions, and many of those conditions are potentially preventable, and people having multiple chronic conditions. So high blood pressure, heart disease, diabetes, all of those things. It makes sense to me to think about how do we integrate those information. People have been doing home blood pressure monitoring for a long time. Now we're able to do things that are more sophisticated. We have to both talk about that as professionals, talk about that as communities, ensure we go back to that foundational health literacy, which is how do we have and encourage and create a culture in which patients are partners in their own healthcare. And I think about it in that context.
Makes perfect sense. I want to talk a little bit about AI. And again, it's a kind of broad question, but when you think about some of the use cases, you have people that are dealing with mental health issues, substance abuse issues, loneliness, and lack of companionship, and just aging issues as well. And AI in many ways can help address a lot of these things, from, even being a kind of addressing some of the companionship, friendship, for example, to education, triage in terms of maybe, I'm having these types of symptoms, and triaging before it gets escalated to a professional nurse or doctor, for instance. How can AI, and certainly more ubiquitously available through their phone, let's say, can be a helpful tool in regards to making healthcare and education accessible to the rural region?
I think that's the question of the moment, in my opinion. And every day that we're reading about new studies, new aspects, new questions about that. And I think that all the major groups, organizations, and educational institutions that I'm working with are asking some of the same questions. I'll tell you a couple things from my public health perspective, which is, some of the concerns are that we have many health disparities, health inequalities. Those were magnified during the pandemic. We know that health is determined by zip code rather than genetic code predominantly. In some cities, there can be as many as a couple of decades of differences in life expectancy, depending which part of the city you live in. So what we have to be careful about, and some of the public health concerns are that we don't want to perpetuate those as we use the data and the information that goes into the systems that are giving us back the information. I think we can do that over time. Then the next thing is that what are some of the applications? And depending who you talk to, there are myriads of applications and everything from diagnostic radiology to looking at biobanks of blood samples and genomics around different things. From a public health perspective, one of the questions I have is, can we use AI to do more what I call precision public health? We know about precision medicine, but precision public health. Can we use AI as an adjunct to help us as we try to modernize our data systems for public health, connecting them to healthcare, to help us figure out which areas of which communities are the highest priority, such that we can best use our limited resources with our partner organizations on the ground to make people's health and lives better. I think it's an open question. I think all of us are thinking about it, and that's kind of how I'm thinking about it.
Fascinating in terms of decision informing and decision making, and of course, even resource allocation and prioritization. So fascinating. My last question is really more around kind of policy implication because of the nature of public health. Many of these constituents are heavily dependent on Medicare and some sort of state level Medicaid programs, let's say. I think it's pretty much common knowledge at this point that we have a rising national debt crisis, and it's just a matter of time before the dollar essentially gets further downgraded. And the Congress, both sides, are unwilling to restructure Social Security and Medicare and just general entitlements. So the reality is, whether we like it or not just the baby boomers, but everyone that's behind them, we're looking at a potentially insolvent Medicare, Medicaid future. And what does that mean for public health? And what are your thoughts?
We've known for a long time that as an example, go back, big picture, our country, life expectancy in our country compared to our peer high income countries is lower. And in the last 20 years, and particularly during the pandemic, we lost 20 years of improvements in life expectancy in our country. And it was already worse than our peer countries. So for me, from a public health perspective, I think we have to step back and regroup. We have to say, how do we strengthen our public health system? How do we integrate the research that we're doing in public health and healthcare and make sure that we're prioritizing some of the advancements in the most prevalent conditions. The NIH does that. I think we have to connect that with the work of our federal and our state and our local public health agencies. I think we have to do everything that we can to improve those both healthcare and social determinants of health, such that we have to avoid, frankly, we have to prevent the need for as much healthcare interventions as we're currently doing. That is a huge cultural shift. I tell everyone that I'm talking to these days that public health has never been more important.
Absolutely. And with that, I have been joined by Dr. Jen Carney, Associate Dean for Public Health and Public Policy, and Professor of Medicine at the University of Vermont. Thanks for joining today.
Thank you.
If you've enjoyed this episode, take a moment to rate our show on any podcast platform that you listen to. Scroll down to the bottom and push 5 stars. It's that easy. And as always, thanks for listening.